myself Dr. Vishal Sharma from UNMICRC Institute of Cardiology and Research Center. Today our talk is on approach to patients with cardiomyopathies. The aim of this small talk is to highlight the importance of cardiomyopathy among younger cardiologists who would be seeing more and more of these patients in their day-to-day practice. So this talk is to guide them to provide a diagnostic approach to cardiomyopathies, highlighting the general evaluation which would help all the cardiologists to form a working diagnosis for their patients with cardiomyopathy. And from this working diagnosis, we can proceed forward for a specific and detailed diagnosis and management of these patients who present to us in our day-to-day practice. However, a detailed description of each cardiomyopathy and recommendations for their management is out of the scope of this talk, but we will be talking briefly about the different types of cardiomyopathies. Just to start with, what is cardiomyopathy? It is a myocardial disorder in which the heart muscle is structurally and functionally abnormal, and this is in the absence of coronary artery disease, hypertension, valvular heart disease or congenital heart disease. And this abnormality in the heart muscle structure and function is sufficient enough to cause myocardial abnormality and symptoms and signs in the patients. This definition applies both to children and adults, and it makes no prior assumptions about the etiology of cardiomyopathy. So our approach now to patients with cardiomyopathy should change, and it should be a patient-centered phenotypic approach. So whenever a patient presents to a physician or say to a cardiologist with specific signs and symptoms of cardiomyopathy, first of all, the physician should have a high suspicion of patients presenting to them with specific symptoms and signs. So how these patients usually present? They usually present with specific symptoms like chest pain, dyspnea, palpitation, syncope or pre-syncope, or as a survivor of a cardiac arrest event. Or they might present to you with some abnormal finding in the form of say abnormal ECG or recording of an abnormal arrhythmia, or the patient might present to you with a finding that a general physician might have got on examination like murmur. Or finally, the patient might present to you as a referred patient due to genetic screening. So whenever such a patient presents to you, you must have a high suspicion of cardiomyopathy. And how do we approach such a patient? The approach is simple. You need to just have a look at the LV muscle and the RV muscle, or the muscle of the heart. So whenever you can look at the muscle of the heart by simple imaging technique like 2D echocardiography. And in fact, if MRI is available, then you can also go for cardiac imaging in the form of cardiac MRI. Just a little imaging in such subset of patients would help you to achieve a working diagnosis in such group of patients. So detailed assessment by simple 2D echocardiography would help us to classify a patient with heart muscle disease or cardiomyopathy into 5 subset, which would form a working diagnosis upon which we can further develop. So what exactly we have to see on echo? So on echo, we have to see how is the muscle. So structurally, how is the muscle? How is the muscle of LV? How is the muscle of RV? Is it thickened? Is it hypertrophied? Is the chamber dilated and the LV muscle mass is less? Or if you are going for say cardiac MR imaging, what is the tissue characterization? How is the tissue of the myocardium? So whether they are normal myocytes or there is extra myocyte tissue present within the ventricular wall. So by this simple test of echo and MRI if available, you can see how is the structure of your myocardium. And finally, with the help of echo, you can also define how is the systolic function of LV and RV. Is there any global or regional wall motion abnormality? So is systolic function impaired globally or locally in LV or RV? And finally, you can assess the diastolic function of LV. So by just assessing the say structure of LV and RV and the function of LV and RV in the form of their systolic and diastolic function, just by these two assessments, you can come up to a working diagnosis of cardiomyopathy, and you can classify your patient into one of the 5 following types. which includes HCM or hypertrophic cardiomyopathy, DCM or dilated cardiomyopathy, NDLVC or non-dilated left ventricular cardiomyopathy, ARVC or AVC, that is arrhythmogenic ventricular cardiomyopathy, and finally RCM or restrictive cardiomyopathy. Just to define what exactly these terms means, as most of you already know, but just to brush up, hypertrophic cardiomyopathy is the presence of increased LV muscle wall thickness, that is increased muscle mass in LV and or RV, and which is not due to any loading condition. That is, there is no AS or say hypertension. In the absence of any abnormal loading condition, the patient has increased muscle mass of LV and or RV. What do you mean by DCM? DCM is the dilatation of again LV with or without RV. And in dilated LV, you have either global or regional systolic dysfunction. Again, this dysfunction is not accounted by hypertension, valvular heart disease or coronary artery disease. Sometimes the LV is dilated, but its systolic function and diastolic function is normal. Such cases have been defined as isolated left ventricular dilatation. You need to regularly follow up these patients as they might later present as DCM. Now, what is non-dilated left ventricular cardiomyopathy? In non-dilated left ventricular cardiomyopathy, the left ventricular muscle is replaced by some sort of fatty tissue or fibrous tissue or another infiltration, regardless of the presence of global or regional wall motion abnormalities. So basically the LV is not dilated, the LV wall might not be hypertrophied or the LV mass might not be increased. Still, within the ventricular muscle of LV, there is replacement of myocytes by either fibrofatty tissue or another tissue which is extramyocyte. And in these cases have been defined as non-dilated left ventricular cardiomyopathy. Finally, what is ARVC? It's arrhythmogenic right ventricular cardiomyopathy. Nowadays, it is also known as arrhythmogenic ventricular cardiomyopathy because it might as well involve the left ventricle. Here, there is RV. The RV muscle mass is replaced predominantly by fibrofatty tissue, and at the same time, there is RV dyskinesia with dilatation. And these patients are more prone to arrhythmias. Finally, what is RCM? RCM is a restrictive pathophysiology of left and or right ventricle, and at the same time their volumes are reduced or normal, mostly reduced. The systolic function might be normal or might be reduced. So these are the 5 working diagnoses in which you can place your patient even on the initial examination. So initial examination with the imaging would help you to place your patient in one of the 5 working diagnoses. And then one can work upon a single working diagnosis so as to reach on a detailed final diagnosis and the final management of the patient. Just in epidemiology, in the general population, the prevalence of HCM and DCM is around 0.1 to 0.2%. For ARVC, it is around say 0.07 to 0.1%. Non-dilated left ventricular cardiomyopathy and RCM are relatively rare. So now, how further we approach these patients? Now, this talk won't be to describe each and every cardiomyopathy, but once you have formed a working diagnosis, how by simple tests you can just work up upon that working diagnosis so as to reach a reasonable diagnosis and guide the patient further for further clinical examination or further test and final diagnosis and management. So what you can do is you can use simple examination in your clinic, which includes your detailed personal and family history, a simple clinical examination, you can get an ECG done, and simple laboratory investigations which will help you to achieve a further step up your working diagnosis. So let's start with the history and physical examination. How is history important? History, the age and the sex of the patient, guide you towards a specific diagnosis. Say, for example, whenever you are dealing with HCM and DCM, which are related to, say, some metabolic disorders or congenital dysmorphic disorders, body dysmorphic disorders, these are usually seen in children. Similarly, if you are dealing with, say, RCM of amyloidosis, this is usually seen in adult patients. So if you are dealing, say, HCM or RCM type of working diagnosis of cardiomyopathy and the patient is aged around 60 years, you are most likely dealing with amyloidosis. Similarly, what is the importance of forming a 3 to 4 generation family pedigree? This cannot be emphasized more because it is really important. Most genetic cardiomyopathies, they are autosomal dominant, followed by autosomal recessive, X-linked, and finally mitochondrial variants. So if you have a proper pedigree charting, you can guide the patients for further genetic testing and further evaluation. And which are the all points you must emphasize in terms of family history is that you should ask each and every patient if in their family they have certain events like say premature death or unexplained heart failure, or any of their relative had some sort of pacemaker implanted, or AICD implanted, or had cardiac transplantation. So all these events should be properly evaluated. They should be properly asked to the patient whether any of the family member has suffered any of the disease. From that you can come up to a diagnosis of genetic cardiomyopathy. This is a simple what you can say investigation, or a parameter which you can assess in each and every patient so as to rule out genetic cardiomyopathy. Physical examination, a simple physical examination, what we call general examination in our medicine, would also help you to reach to a specific diagnosis in certain group of patients. Say for example, if the patient you see of heart failure is having some learning difficulties, sensoriural, some sort of deafness, or some sort of visual impairments, or something related to cranial nerves, or brain, then you are mostly dealing with some sort of mitochondrial impairment which is seen in HCM and DCM, the genetic forms of HCM and DCM. Similarly, say if the patient is having skeletal muscle abnormality in the presence of HCM or DCM, then you are most likely dealing with some sort of desmosome abnormality. And so see, these are the simple pointers which would help you to reach to a diagnosis of genetic cardiomyopathy. ECG is one of the simplest tests. A 12-lead ECG is the first test, in fact, in most of the patients that would point towards their diagnosis of cardiomyopathy. Although in some group of patients ECG might be normal, but ECG abnormalities are mostly present in all cardiomyopathy subtypes, and in fact ECG abnormality might precede the development of an overt morphological or functional phenotype of cardiomyopathy by many years. So let us see how simple ECG findings might lead to a specific diagnosis of cardiomyopathy. Say in HCM, we all know that there is LVH, but if in same HCM patient there is extreme LVH, so R wave voltage is going beyond 30-40 mm, then you are probably dealing with a storage disorder in the form of say glycogenosis. Say for example, Pompe's disease in children and adults onset Pompe's disease, or say for that matter Dannon's disease, or for that matter PRKAJ2 mutations. So these are lysosome or storage disorders involving glycogen which is seen in HCM patients, and these patients specifically have this abnormality of having extreme LVH on ECG. Similarly, in HCM patients, if instead of LVH you are finding low voltages, you are finding loss of truncated R waves in NTLs, or what we call the pseudo-infarct pattern, then you are dealing with infiltrative disorder which is extramyocyte, say for example amyloidosis. In younger patients this would be multiple myeloma, and in older patients you would be dealing with TTR amyloidosis. Similarly, in DCM patients mostly the voltages are low, as we understand, but at the same time if you find that the P wave voltages are very less, or there is atrial standstill, you are probably dealing with the Emery-Dreyfus type of associated dilated cardiomyopathy. Similarly, if the voltages are out of proportion small, the QRS voltages in patients with DCM, you are most likely dealing with a phospholamban variant of dilated cardiomyopathy. So simple findings on ECG, in fact 12-lead ECG, also help you to narrow down further your specific diagnosis of cardiomyopathy. Laboratory investigations. Now, simple laboratory investigations in fact can also help you to narrow down your specific diagnosis of cardiomyopathy. Say for example, if the patient of cardiomyopathy, any working diagnosis form of cardiomyopathy, he presents with elevated levels of creatine kinase persistently, then you are mostly dealing with conditions which are involving both myocytes as well as neuromuscular disorders. Say for example, dystrophinopathies like Becker's or Duchenne's, find laminopathies, desminopathies. So patients who have some sort of desmosomal disorders which are also affecting not only myocytes but also skeletal muscles and other muscle groups, these are the patients who will present with this creatine kinase elevated persistently, and which can be done very easily. Similarly, say if a patient has presented to with myocarditis like episode, and you are finding that the CRP is raised, and RV is showing dyskinesia, RV wall is thinned, you might be dealing with the setting up of either ARVC or ARVC, which usually presents initially like myocarditis or is deteriorated by myocarditis. This is the also finding which is seen in non-dilated left ventricular cardiomyopathy. Also, if on simple investigations like you find elevated levels of serum lactate persistently, you find leukocytopenia, or you find in urine myoglobin, then you are dealing some sort of mitochondrial disorder, and this might be a genetic cardiomyopathy involving mitochondria. So as we had previously discussed, simple imaging techniques, although you can use say echo, MRI, CT scan, nuclear imaging, but I believe simple 2D echo and cardiac MRI, if available, helps you to really put your patient in one of the 5 working diagnoses, and in fact it also helps you narrow down further diagnosis in these patients with cardiomyopathy, and they are really useful. Cardiac MRI, in addition to echocardiography, not only provides you detailed structure and functional evaluation in LV and RV, it also has the ability to characterize what tissue the abnormal myocardium has. And this later advantage is particularly important in the diagnosis of non-dilated cardiomyopathy, ARVC, myocarditis, amyloidosis, sarcoidosis, and other form of inflammatory diseases like iron overload hemochromatosis. Other imaging modalities can be used and they would be required for the specific diagnosis of a particular cardiomyopathy. So as we discussed, by simple investigations, say for example a detailed history, a physical examination, ECG, echocardiography, and simple lab investigations, you can reach in your patients one of the 5 working diagnoses, and in fact narrow down to a specific diagnosis also even by these simple investigations. You might require extra investigation for specific patients, which would be talking about in other lecture. But today, by these simple investigations, how we can diagnose a patient with cardiomyopathy, we have learned. And now I'll present a case which presented to our institute few weeks back. So this was a 17-year-old male who presented to us with palpitation. So we took a detailed history of him. When do you present with palpitation? Is it exertional? So this was non-exertional palpitation, and he was having this palpitation since 1 to 2 years. Then we took a detailed family history. What we found that his uncle had a history of sudden cardiac death. We saw the general looks of him. He was normal, no sensory deafness. His vision was also normal, and overall intelligent quotient, the IQ was also normal. No other abnormality on gross physical examination was seen. We next went to ECG, our standard 12-lead ECG. A standard 12-lead ECG, it showed sinus rhythm. There was minor intraventricular conduction delay. There were few VPCs. We got a Holter turn, which also showed. The Holter also showed that there were extra systoles, which were like I think 1 to 2%, and there were couplets bigemini and some trigemini. Then when we went to the standard examination, that is our 2D echocardiography. On 2D echocardiography, what we found was the LV was neither thick nor it was dilated. Similarly, the RV was also not thick nor it was dilated. The systolic function and the diastolic function of both LV and RV were appearing normal. So basically, it was a normal echo. On echo, the structure and the function of both the ventricles appear to be normal. But since we suspected that this patient is having palpitation with a strong family history, we went on to the second examination which we commonly do at our institute, that is cardiac MR. On MR, what we found was there was subepicardial scar in the posterolateral wall of LV. Having scar in the posterolateral wall of LV is commonly seen in patients with genetic cardiomyopathy, and these are the patient, and the scarring in this area, especially subepicardial, is seen in patients who have some defect of desmosomes. Desmosomes are, as we all understand, they are involved in cell-to-cell interactions. So, understanding this, we went for a genetic study in this patient, and we found that the desmoplakin gene mutation was there. This was the deficient protein there. And finally, as we saw from a simple presentation of the patient, hearing his complaints, going for a detailed family history, an ECG, a Holter, echo, and finally MRI, helped us in reaching a working diagnosis. So from up till here, from just the complaints of the patient, the family history, ECG, echo and MRI, we reached up to diagnosis the patient is having some sort of non-dilated left ventricular cardiomyopathy. We added the investigation of, say, genetic screening, because MRI showed us subepicardial scar in the posterolateral wall, and that genetic screening showed us that the patient was having mutation in desmoplakin. So you can see how just by a step-ladder approach we reached to a specific diagnosis of non-dilated left ventricular cardiomyopathy, autosomal dominant related to desmoplakin with subepicardial scar and a normal ejection fraction. So this is how we reached up to a specific diagnosis in this patient using simple approach, simple tests initially, and as the test suggested, upgrading the test and the technology that is available, and finally going to genetic screening to reach the final diagnosis. This patient was gradually followed up. He had arrhythmia, so finally ICD was placed and he is doing fine. So, this talk is to emphasize the fact that cardiomyopathy forms a major chunk of patients, in fact, which would be presenting day to day in most of the OPD practice of cardiologists, and they need to understand the fact that simple examinations, simple approach of history, physical examination, ECG, a detailed echo and lab investigations would help them to reach a working diagnosis, and reaching this working diagnosis is really important, so you can then fine tune further investigations to reach to a specific diagnosis. This approach has also been highlighted and emphasized upon in most of the international guidelines and international heart failure societies, and should be used more and more by not only the cardiologists but also the physicians, so that they can help these patients with cardiomyopathy, which are usually neglected or usually missed in this today's era of interventional cardiology. So thank you all for your patient hearing, and I would be glad that in the future I would be talking in more detail about other cardiomyopathies. Thank you so much.